afternoon, everybody. Yes, my name is Stuart Schlossman of MS Views and News. I'm the president and founder, and we wanted to welcome you all here today. We are going to be doing a new type of program, and we are having three speakers. We have Jeff Siegel, who's a personal trainer. We have Kathleen Smith, who is going to be speaking about cognitive change challenges, cognitive training, and cognitive therapies. And then, for all of you that already know, we got Dr. LaGanke that's going to be here, and he's going to be speaking about an overview of multiple sclerosis, different types of MS, shared decision-making, what makes a comprehensive healthcare team, and so much more. I can't wait for you all to listen to this. And by the way, before we begin, I want you all to know that we were sponsored by Sanofi-Genzyme and Celgene, and let's give them a round of applause. We're going to have a good round of applause for our next speaker, right? And so, I don't have an intro to say for him because I've just known Dr. LaGanke way too long. And by the way, I was told that I have to stand here and try to show you how I've gotten some balance as well. So I'm going to have to try to do this. Oh, I'm going to fall. Never mind. Anyway, Dr. LaGanke. Dr. LaGanke, many of you know him already. He's from Coleman, Alabama. He's the executor, I guess you could say, of the Joan P. LaGanke Center. And Dr. LaGanke is very well known around the world. We love asking him to speak at programs here in Alabama, as well as I've had Dr. LaGanke come to South Florida to speak, and we want to use him in other places too, if he can remember to open up some of his schedule. Okay? So let's welcome Dr. LaGanke. That wasn't loud enough. That is better. Talk directly in, please. Thank you.
We don't want to poke the bear, though, right? We do it loud, they do it louder. And the clicker, yeah, great, good. Okay, well, thank you all for coming out on a Saturday, and as was mentioned for quite some time, it's a lengthy program, and hopefully you get value out of each of the sections. I know the last two sections were really quite informative. Helped me to kind of deliver some messages, too, in clinic, so appreciate those talks. So my talk's really not to talk about particular medications to treat MS, but more talk about MS, give kind of a background of MS, things to think about, things you probably don't know that are correlated with MS, and then just some hodgepodge facts at the end that hopefully are going to be fun and helpful. So, with regard to the MS knowledge part to begin with, just some quick facts about MS and a little bit very briefly on pathophysiology, some cofactors, how we diagnose MS, and then some other soapbox kind of things. So seriously, I always like to start to set the tone with why are we here? Because this is a very serious condition. This really affects people in a whole lot of ways. It's the number one atraumatic neurological condition, disabling condition in the world for young and middle-aged adults. Untreated, it's a fatal condition, 7 years lost life on average. It's one of the top 3 neurological conditions that has suicidal ideations, and it is the top neurological conditions with completed suicide. So this is a very serious condition, and fortunately we have had the benefit of treatments that have allowed us to manage this a whole lot better than we did 20, 30 years ago. That maybe lessens the severity or how serious this condition can be. Because back in the day when I started my training, there were no treatments for this condition. It was one of the worst diagnoses we wanted to give. We didn't want to give, but we had to give. We just did not, we had nothing to do for it and just felt horrible. People in the prime of their life, neurologically affected, and we kind of knew from natural history what was going to happen. So we're very blessed to have a lot of treatments, but sometimes that makes us a little lackadaisical, and we don't realize the severity of this disease in its true form. The challenges still are there, though, for someone who's newly diagnosed or recently diagnosed, and with a severe relapse, for example. All of these things up here, job alterations, loss of employment, changed ability to raise a family in whatever way that might be, strained marriage, lack of intimacy sometimes, fear of the unknown, physical changes, and how you deal with the fact that you're physically different, gender role changes, maybe you were the breadwinner and now you're not the breadwinner type things, social isolation. I mean, all of these sorts of things are real issues that confront many people with MS. The incidence is, in the US, 1 in 400,000, in the world about 2.5 million. These are 1990 statistics, and I say this at every single program, so you probably tune me out when this slide comes on, because it's still 1990 statistics, and funding is based on these sorts of things. So is this really appropriate? I would say no. Okay? No, this is not appropriate. We need a better census, and we need a better way to capture the actual incidence, because one person is diagnosed every hour in the United States. One person does not die from MS every hour. So it just makes logical sense that those numbers are still not relevant today. This is a genetic condition, right? It's not necessarily brown eyes, blue eyes genetics, but it definitely is a genetic condition where you have to have the background, you have to have the ability genetically to have this disease, and then likely you have an exposure to something that triggers it. There are over 100 genes so far identified and many more to come, and our ability to detect gene abnormalities is better and better, so this number I expect in the next couple of years is really going to increase. There are some other things that I'll talk about: vitamin D, Epstein-Barr virus, smoking. These have an impact on your genes. So it's not just a habit, it's not just a deficiency, but there are things that happen to your chromosomes, to your genetic material when you have deficiencies or you have exposures to some of these things, and that's called epigenetics. Natural history sort of thing, and I could have 15 slides on the natural history, but just some to put out there. An EDSS is a disability score, and we use those in our trials to measure success or lack of success of treatments over time and get an idea roughly of where you are on a mobility scale, basically. Well, once one hits 4, then it's a very slippery slope on down to the cane and the walker. So, you know, we have certain targets we need to be mindful of and say we're nearing this sort of disability. We need to really intervene. I mean, I would challenge that we need to intervene with that kind of effort from the very beginning, but we really need to be very cognizant if someone comes in who's nearing that disability score. And I'm going to talk about risks for earlier age to disability, so young age, male, African American are risk factors that are higher to reach disability sooner. And the progressive phase I'm going to talk about subsequently. So how does MS affect the body? Well, this would be a normal, healthy nerve. As you can see, those little sausage links are the myelin, and there's a little node of Ranvier in between each one. That's where the charge gets regenerated. So the charge comes along, it zips on the outside of the myelin, hits that little node, gets reinvigorated, goes to the next one, and you could snap your fingers and do a lot of things. So I do this all the time. So I had to think about snapping my fingers. It had to go to the motor cortex. It had to go down, cross over, go through the spinal cord, go to the muscles that actually contract. It also had to send signals to the opposite muscles to paralyze them so they don't interfere with the contraction. Also had to send a signal to the balance center so it's not like this, all like that. So this transmission is extremely fast and very efficient with a healthy nerve. A damaged nerve, or a demyelinated nerve, however, you see has a blank area there without the, not that one. I think my myelin misfired a little bit. So you have this area here where you have no myelin, so once you go here, then how does the signal get over here? Well, it has to open and close every sodium-potassium channel here, which requires 3 molecules of ATP. That chews up a lot of energy. So just doing routine things along some scarred nerves is going to chew up your energy a whole lot faster. That's why we have fatigue in MS. So you use as much energy as I will by noon, 1 o'clock in my whole day. Yours is spent by noon because you're chewing up a lot of energy just trying to transmit a signal. Now, if you go to this point where you transect the axon or the nerve or the wire, then you're not going to have any transmission downstream, and you're going to have usually some obvious deficits. And on our MRI scan, that area is a black hole, if you've ever heard that terminology. But what we see is only on the surface, right? There's a lot going on underneath the surface. And how many of you have been told or implicated, but you look so good? I don't understand why you can't do this. You look fine. I see a lot of smiles out there. It's a very commonplace comment made in my clinic. And it's from well-meaning people, so even loved ones that look at you and you look just perfectly fine and you're not going to take the trash out. And they don't understand. Okay, but there's a lot more going on underneath. And we're going to talk about some of those. Now, briefly to sort of technical aspects of MS, and this is really cartoonish. There's so much more depth to this. B and T cells first. These are our lymphocytes, and these are the main players, we would say, in MS. The B cells secrete antibodies. They also turn on T cells to invigorate them, kind of like Pac-Man, and then they get going. T cells actually cause direct destruction. B cells do as well. But they're both kind of working. T cells down here go across the blood-brain barrier, and then they get reinvigorated, and they damage the myelin. B cells come over here. They turn on some T cells. They also secrete antibodies right here and can also damage myelin. So these cells have long been the stars in who we look at as the bad players in MS. These have drawn most of our efforts for therapeutics to try to intervene in reducing T cell function or keeping them out of the central nervous system or altering B cells or destroying B cells so they can't do their thing. A couple newer players, though, microglia. Microglia is probably the most common immune cell inside the central nervous system. It's kind of like a macrophage that's in our general system outside of the brain. And there's a reference here from this author who I'm giving credit to for this picture. So here you have some microglia that's on the other side of the blood-brain barrier, this being inside the blood vessel, this over here being inside the brain. Well, there are different types of microglia, and depending on which ones get turned on, you're going to have a different response. Some microglia remyelinate. They help. Some microglia damage the myelin. So it's that inflammatory milieu or environment that really triggers which ones, and typically the remyelinating ones are stimulated more after the cleanup. The initial insult, the microglia that are stimulated are the inflammatory ones. So trying to figure out how do we turn the good ones on and turn off the bad ones is something that's actively being pursued at the present. And astrocytes, so these are the kind of support system inside the central nervous system. Astrocytes kind of keep the blood-brain barrier intact. They kind of have 2 feet that push up against the blood vessel wall and keep them intact and strong. But astrocytes do a lot of things, turning on T cells and creating certain chemicals that then increase inflammation or decrease inflammation, depending, again, on the local environment and what the triggers are. So this is really not for you to remember with any kind of detail, but just that there are a lot of complex factors, some of which are just new to our understanding as far as impact in MS and may lead us to some very good therapeutic options down the road now that we know that they're directly involved in some of the damage. This would be the grand pictorial cartoon then, just that kind of brings it all together. So you have the lymph node over here, which turns on the T cells to direct them to go to the brain. So the T cells are kind of average Joe. They go to the lymph node, they get turned on, again, something like Pac-Man, and they're different. So they can bind to a target on the blood vessel wall, and then when they slow down from binding, they're able to get into the brain. They get into the brain, they get re-stimulated, and then they turn on microglia, they interact with B cells, and the cascade of inflammatory damage occurs. They also send some chemicals back that makes the blood vessel wall leaky, so more cells can easily get in and cause more damage. Here's the epigenetics, one slide I want to talk about. So there are certain things that can happen to the genes and the DNA inside the nucleus of a cell when you have a vitamin D deficiency or you smoke. Epstein-Barr virus, actually some of its particles can intercalate into the DNA, which then turn on certain signals. There are start signals and stop signals when we encode on the DNA, when we make proteins, when we think, when we do anything. So some of these DNA methylations and histone modifications can occur because of the environment. So maybe genetically, you're pretty insulated from MS. You do have a little bit of ability if X gets turned on or Y gets stimulated inside the genes. And so this is called epigenetic because it's not that you receive the genes and you're going to have the problem, but you have a susceptibility if you're exposed to this or that to create the problem that turns on the inflammatory cycle. So epigenetics is another thing that we can modify. So as long as we identify more and more features that can adversely stimulate the genes, then we need to work on those, like have an adequate vitamin D level, make sure that we're stopping smoking as best we can, those sorts of things. So what are the common symptoms then in MS? So that was more pathophysiological and behind the scenes. This is more, what do you experience now? So fatigue, 80 to 90% of people with MS have meaningful fatigue at some point during their course, if not all the time. Numbness and tingling, 75%. Sexual dysfunction, 50 to 80%. Cognitive issues, optic neuritis, 70%. Muscle weakness, heat sensitivity, 60 to 65%. Bladder dysfunction, depression, constipation, 60%. And anxiety, sleep disorders, and migraine, 50%. That's a lot of symptoms with a greater than 50% chance of having them. So that's a lot that we have to deal with, that you have to deal with, and then we try to help you to deal with. There are some pearls you can learn. So if someone comes in with bilateral blurred vision that's changed over the last several weeks, very unlikely that it's due to MS. Almost never does it affect both optic nerves at the same time. Now, if you're seeing double, frankly, or having some beady eyes where the nystagmus is making things hard to focus, then yes, both eyes can be affected, but it's very, very rare to have optic neuritis in both eyes at the same time. So blurred vision is going to be probably more of an ocular issue or a medication side effect. Dizziness. Dizziness, on the other hand, is often not attributed to MS, and be surprised at how many people with MS have dizziness in their history at some point, and it wasn't just a true and unrelated. It was related to the MS, but it hasn't really made its way into the literature as a legitimate relapse quality symptom. So dizziness, yes, if you've been told dizziness is not MS related in the past, it may well be. Old symptoms returning. So let's say that original deficit was paralysis on the right side, and fortunately you healed up from that, and 4 years later the right side gets weak again. Very unlikely that you're having new damage to your central nervous system. More likely you have some stress going on that's making it hard to conduct through that pathway. And I go through phases or things that I learn and then recite those over and over because they're practical and helpful, or sanctification, I guess. I get better at it over time, better message. What I've been saying lately is that weak areas don't do very well under stress. You take a quarterback, he's very weak, you blitz him, he doesn't do very well. You have a building that's on a weak foundation and you have a windstorm, it's probably going to teeter a little bit more than the one on a firm foundation. Well, when you have weakened circuits and you stress the body, they don't put out as well. So that right side of weakness comes back again. And stress doesn't mean negative. Right? It doesn't automatically mean something negative. It's just extra effort on your system. So you go and work out a little bit longer, and ooh, my hand's numb because I was working out. Or you're out in the heat for 3 hours, or you have a bladder infection, or marital strife, or any sort of stressor. You didn't sleep well for a few nights, you're missing meals, you're dehydrated. Those in combination can be just enough stress to bring out an old symptom. So an old symptom coming back, unlikely that you're going to need steroids to restore your function. More likely we're going to have to modify something if we can. And then bilateral limb dysfunction. So if you had numbness in both hands or both feet or weakness that ascended up your body, it's going to likely be in the spinal cord. And you need to know that because sometimes phone call, if you start a message here and whisper it around the table, it kind of is a little different at the other side. So you call the office and the message goes here and here and here. And the message came across that Johnny's doing worse. Let's get a brain MRI scan. Hey, we didn't see any active lesions or new lesions on your brain MRI. You're not having a new problem with your MS. Problem is you didn't image the spine because the symptoms told you where the problem was. So bilateral symptoms creeping up or starting one leg, go to the other pretty quickly, likely the spinal cord is causing you a problem. And comorbid conditions. So this is, you heard talk about this earlier. These are real bad players. Okay, and I picked these 5 because they occur with a rather striking frequency. So anxiety disorder, over 50% of people with MS have an anxiety disorder. It's not because, I have MS and I can't do anything. It's a physical problem of the brain, just like depression is. It's just like hypertension or diabetes or MS itself. This is not some mental illness. This is a physical illness. And yes, they are worsened by stress or psychological issues can worsen them, but they didn't cause them. This has a physical substrate. And all too often a person is made to feel guilty that you just need to get over it. Well, you're not going to just get over your diabetes or your arthritis without some sort of intervention usually, right? Or you don't pray enough. I mean, you hear that. Certainly power of prayer is very strong, and the Lord can do anything. But that's not necessarily why you're having anxiety or depression at that time. Chronic pain, something also that's kind of not well appreciated in the literature. When my mom was diagnosed at Yale in the 1960s, they told my dad, they said, well, if there's anything positive about this condition or things that aren't going to be affected, it's cognition and pain. She won't have any pain and she won't have any cognitive problems. Okay, that was the 60s. We know now over 50% of people have both of those things. Migraine disorder, used to think they were true and unrelated. There's a 2 times higher incidence of migraine in individuals with MS and about a 46% incidence. And sleep disorders, they're very, very common. And so I'm going to go into these just a little bit, little pearls of these conditions. But this is the complicated MS patient in front of us. So it's not just nerve conduction difficulties. These conditions are likely, a couple of them are going to be at hand. Anxiety disorder. When you have anxiety disorder, you have more sleep disorder. You also don't treat, your pain isn't treated as well with the routine pain medications or pain modalities. So they interplay with each other. One aggravates the other. In the United States, and I think this is really important because of the opioid crisis and the attention that's being given to the opioid crisis. In the US, the last numbers we have cumulatively for suicide, 45,000 individuals unfortunately committed suicide in the United States in 2016. Anxiety disorder of some sort or another was present in 70%. The rate of death with suicide is faster year by year in the last decade in the US than opioid overdose. Now, 30% of opioid overdoses have some anti-anxiety medicine found in the system. They didn't say, how much, whether it's high or low, but a combination of anti-anxiety medicine plus a narcotic at the opioid overdose. So that's a large number, and unfortunately, the reaction right now is you can have one or the other. So I've seen this many times. People come back from the pain center, a pain clinic that they were referred to, and the pain center was directed to say you can have either an anxiety medicine or a pain medication, but not both. And I as well, from the state, directed in that way. Okay, so there's a problem there. Yes, we will reduce overdose deaths with a combination of anti-anxiety medicine and opioids in the system, but we're going to have a lot more anxious people who commit more suicide. And we have to be mindful of, yes, I took care of this problem and I was blinded to another problem that is just as bad, if not worse. So a knee-jerk reaction to one, is not the appropriate way to handle this situation. Depressive disorder. Well, the 12-month prevalence and the lifetime prevalence of depression is twice that of the general population. And again, not due to woe is me, life's bad. That's not what we're talking about with depression. Actual chemically mediated depression. It is significantly associated with fatigue. And when it is combined with MS, depressive disorder, pain medication utilization is higher. Visits to the healthcare providers for pain is higher, and the number of pain medications used in that given individual is higher. The World Health Organization estimates that by 2020, that's not very far from now, major depressive disorder will be the world's second most cause of disease burden behind ischemic heart disease. So it's a real player. It's not just a you need to get over it kind of a condition. This is a real medical problem. Chronic pain. Well, pain is in the brain, right? So you can stub your foot, but if you didn't have pain perception area in the brain, it doesn't hurt. Pain is in the brain, and MS damages the brain. So do you interpret pain signals like you ought to? Sometimes not. Okay? Compared with the non-MS population, pain was commonly more severe and produced more significant impact on daily life. So pain with MS, worse impact. Living with chronic pain significantly increases 4 of the things I already talked about. So you see there's this interplay. If you have more anxiety, you're not sleeping very well. Not sleeping very well, you feel pain more, et cetera, et cetera. They play with each other and aggravate each other in a vicious kind of a way. So if we can intervene successfully in one, likely we're going to have some positive impact on another. And in a recent study, it was shown that MS patients typically have 2 different pain syndromes going on at the same time. Also, a study by Marie demonstrated a higher incidence of suicide in people with MS who have chronic pain, one of the chronic pain conditions. Increased falling when a patient with MS has chronic pain, higher healthcare utilizations than someone who doesn't have chronic pain, et cetera, as you can see there. So many significant impacts is chronic pain. It's not take a Tylenol or we have to reduce the opioid crisis. You can't have any pain medications that are more stout than this and this. Certainly, we need to look at ways to treat pain outside of medication, but medication sometimes is necessary, and we shouldn't have an absolutely no policy as far as that goes, or a limit for that matter. So what are the aspects of chronic pain? Several studies look at brain chemical function in normal areas in chronic pain, and the whole brain, NAA, glutamate, and inositol, which are certain neurochemicals that look at astrocyte health and other type of health, are chronically adversely affected. So having chronic pain changes your brain, not just while you're having pain, permanently changes your brain if you have chronic pain for long enough. There's 11% atrophy of the brain. That's not coming back. And when MS patients have atrophy 5 to 10 times greater than the general population untreated, that extra 11% isn't welcomed. Okay? We know that MS and chronic low back pain patients, we've done studies that look at amygdala atrophy. Amygdala kind of gives your emotional perception to pain and quality to pain. People just with osteoarthritis, not MS, there's caudate nucleus atrophy, which is one of the basal ganglia nuclei, which is with our movements, Parkinson's, and so on and so forth. So pain isn't just, ouch, it hurts, put a Band-Aid on it, take a medication. Chronic pain has brain-changing features, and when you have a condition that already has a damaged brain, you don't want not to treat something that's going to aggravate and cause more brain damage. That's outside of your MS. Migraine disorder, as I said, about 46% of individuals with MS have migraine in the recent study. Surprisingly to me, 6th most disabling condition in the world, migraine. And migraine is not an event. It's a brain disorder. It's a genetic condition, and there are a lot of projections inside the brain from the thalamus that are altered with migraine, just by having migraine, whether it's episodic or it's frequent. And I listed several areas of the brain that have diminished gray matter that are important in processing pain. So when you have MS and you already have pain, and then you have migraine on top, you're not able to process pain signals so well. So these comorbid conditions, where you might say, well, you have depression, oh, I have anxiety, these are serious things on top of an organ that already has some compromise. Lastly, sleep disorder. So there's several different types of sleep disorder, like restless leg syndrome, REM behavior disorder, insomnias, the sleep-related breathing disorders, periodic limb movement disorder, that are much higher in incidence in people with MS than in the general population. And then we have a lot of other things. Anxiety makes sleep worse, spasticity, or that stiffness that you have, those muscle cramps that are so friendly to wake you up at night. Those things occur and interfere with your sleep. Narcolepsy is much more common, etc. Side effects of medications. And poor sleep is associated with hyperalgesia, which means that you feel pain a whole lot more at a less stimulation than somebody else. So you're more sensitive to feeling pain for less stimulus. And these are all sort of bidirectional, as I said. So if you have bad sleep, you're going to feel pain worse. You're going to be more anxious. More anxiety leads to worse sleep. That depresses you. If you're depressed, you're going to have less good sleep. You're more likely to have anxiety. So these are all interrelated, okay? And not just casual symptoms. Shifting gears then to the types of MS, we have progressive relapsing, which really is kind of falling out of favor. It's kind of lumped into relapsing remitting MS. You have secondary progressive MS, primary progressive MS, and relapsing remitting MS. And as you can see, that the line here slopes up for all the progressives, which means the baseline generally is getting worse in between attacks, whereas relapsing remitting, you'll have some period, which can be a honeymoon of 8 years even, of no change, and then a relapse. So here you have some baseline of normalcy, meaning, or baseline of stability, I should say. And that's important, because I have some people every year, some patients come in and say, when am I ever going to go in remission? Thinking that remission means normal. And remission doesn't mean normal. Remission means you're not progressing. You're not adding new neurological deficits. So you may have some stable neurological deficit, and if you're not progressing, you're still in relapsing remitting MS. Now, radiographically isolated syndrome was first described in 2009, and this is an individual who has a brain that looks all the world like MS, but has never had a symptom at all. And this has been brought forth by Dr. Acuto out of Texas. And really what's helpful is if you think that happens, someone had an MRI scan because they had a headache, and boy, that looks really like an MS type of an MRI, which happens at times. Important thing to do at that point is to have the neck looked at, because if there are cervical spine lesions, 90% of people are going to go on to have MS clinically definite over time. And you can, in fact, even say that it is and treat them, because wouldn't it be great if you had MS and you never had a symptom in your whole lifetime? Wouldn't that be the best situation, which kind of goes hand in hand with treating earlier, so you have less, the better? And some might say, well, what's the rush? I don't have any symptoms, so what's the big deal, right? We'll wait till something happens. Well, one, when you have that attack, you've lost your sense of normalcy for the rest of your life, always wondering what might happen. Relapses cost money, and as you'll see in a few slides, about 50% of people have a permanent change once they have a relapse. And then we know if we control the disease early, you don't let the fire expand, you put it out early, you have much better long-term outcomes. Clinically isolated syndrome, this term's kind of going away more now. This is when you had one event, and so you don't have multiple sclerosis because you haven't had multiple events, so it's clinically isolated. It's one attack that's very typical of MS, but you haven't had that second one yet. Well, now we've sort of changed how we analyze that, and if you have one attack and two lesions, one of them being active, then we can say it's MS. So we don't have to go through this semantic process of we know that you have a 90+% chance of having clinically definite MS over time. Let's go ahead and treat it and keep you from having any neurological deficits accumulate. Now, the McDonald criteria, has everyone heard about the McDonald criteria? So this is the criteria set forth for us to help us to diagnose people with MS. And it came out around 2000, the first McDonald criteria. And we've had several revisions. Well, we had a revision last year. And one of the things was primary progressive MS is now kind of divided into 4 different types or 4 different descriptors of primary progressive, which is a change from just primary progressive. And then the other part that was really salient was, and that's these next 3 slides, which I won't kind of go over, but get you to the meat of it, is that now we can use spinal fluid in clinically isolated syndrome. If you had optic neuritis and you had a lesion and we do a spinal tap and there's inflammation, now we can say it's MS. That counts for something. Whereas spinal fluid otherwise has gone out of the McDonald criteria as being something that we really need to do in MS. So now here on this slide, the very bottom part, is 2 additional categories are proposed for primary progressive MS. So you can have active or non-active primary progressive MS based on whether you had a recent relapse or new lesion. And you can have progression or non-progression based on physical worsening. So you can have active non-progressive primary MS, or you can have active progressive primary progressive MS, you can have non-active, so you can have the combination of those to give you 4 different possibilities to define your primary progressive MS. And CSF, as I mentioned. So when we go towards the diagnosis, we also have to rule out the mimics, because there are certain conditions that look exactly like MS, like sarcoidosis and lupus and rheumatoid arthritis even. There are several that we need to rule out and exclude because they can look exactly the same on MRI and physically as MS does. And then NMO spectrum disorder, so neuromyelitis optica, also called Devick's disease. There's a spectrum of that now where it's not so severe necessarily at the beginning, where it's really clear to tell a difference where a person's quadriplegic and blind very quickly. That's NMO. But NMO spectrum disorder has much more subtle abnormalities, and NMO spectrum disorder does not respond to MS treatments very well. So we don't want to go down the wrong tree. We don't want to misdiagnose if we can help it. And something that maybe you've run into before, and it's really frustrating, is to be told, as a 40-year-old with several white matter lesions, they may not be classic MS white matter lesions. You've had a deficit. Everything kind of fits for MS, but the MRI is maybe not there, or the spinal fluid was normal, and you're told, it's not MS. I can't tell you what you have, but you don't have MS. They're very sure about that. Where 10 years ago, where we were sure about people not having MS, now they're meet the diagnostic criteria. So it's evolving to diagnose people sooner, and not everything fits into a perfect diagnostic box. So some conditions or states are very difficult early to say, is this MS or is this not MS? And unfortunately, some people want to have very rigid boxes in the diagnosis, and they're diagnosed with MS later on after being told this. And spinal fluid, still, that it used to be, we used to spinal tap every single patient with MS in the day gone by, and it was said that 90 to 95% of people with MS have an abnormal spinal fluid. That stats continue to go around, but through many different studies and looking in different populations around the world, about 30% of people with MS have normal spinal fluid. And also, spinal fluid can normalize in MS, where that was previously stated not to occur, because of some of our treatments. Some of our treatments, when the person goes on an infusion treatment, have spinal fluid tap later on, it may be normalized, which we didn't think could happen before. So unfortunately, some clinicians, if you don't have abnormal spinal fluid, you don't have MS, and that needs to go away too. It was removed, spinal fluid as being important in the diagnosis of MS was removed from the McDonald criteria several McDonald criteria ago. Now, secondary progressive disease is when you start out with relapsing remitting, and then there's this gradual decline, sort of maybe a wearing out of the old lesions. Well, we have done a tremendous job at reducing secondary progressive MS. That's because we had very good, effective treatments to treat relapsing remitting MS. And if we limit the damage, the brain can handle that, and we don't see a wearing out and less reserve over time, where then you develop this pattern where that right limb, which was mildly weak, maybe a foot drop to start with, now the whole leg's not working very well. That would be secondary progressive disease over time with no new lesions. So fortunately, many less wheelchairs in our waiting areas as 15 years ago, because early intervention has stopped that cascade from happening. Primary progressive MS, fortunately not as common. We did not have a treatment until last year. First treatment we've had available for primary progressive MS, which is a blessing to have that available. But here one just continues to decline over time without necessarily having a relapse. DIS means dissemination in space, and DIT is dissemination in time. And in the past, to diagnose MS, you had to have both. You had to have a change in time with another area, not the same area. So if you had optic neuritis and you had another bout of optic neuritis, that wouldn't count as two separate episodes. Yes, you had two episodes separated in time, but not in space. So you have to have two different areas of the central nervous system affected, and it has to be at two different points. Now, like I said, the criteria allow us to diagnose with one event if the MRI helps us enough, or maybe the spinal fluid and CIS. 90% of people with primary progressive MS start with walking difficulty, whereas with relapsing remitting, the majority are either optic neuritis or other visual dysfunction or a sensory problem. There are smaller numbers of lesions and less enhancement in people with primary progressive MS. So it seems kind of like a different immunological variant of MS. Higher proportion of lesions are in the spinal cord. Average age of diagnosis is 10 years later. And males have equal incidence with females, whereas in relapsing remitting, females have twice as many, 2 to 3 times as often MS as males. So it evens out with primary progressive. All right, so one of the tasks that Stuart asked me to talk about was early treatment. And so I was just kind of thinking of reasons, and you may have some other ones, of why wouldn't we start treatment real early when you're first diagnosed, you had optic neuritis, your eye improved, you really don't have any deficits. That's the discussion of should we have treatment or not. The cons would be, well, can't predict how I'm going to do. I might do real well. So why would I take this medication? Because I might just fare real well. You can't tell me I won't, and that's true. Side effects of medications, there are safety issues with our treatments. Those are things that have to weigh into whether we take this medicine or take any at all. There's cost associated with it. There's effort to get the medication, effort to take the medication. And do we know 30-year long-term benefits? No, the medications have only been out 25, the oldest one, and the others haven't been out that far. So do we really know the long-term benefits? Is it really valid over time? And then are there some natural alternatives? Surely to goodness there has to be a natural product that can help my condition somewhere, right? So those would be, I think, reasons people who would opt not to have early treatment, those may be some of the things that they would proffer as far as that goes. On the other side, can't predict individual responses. So I can't predict that I'm going to do well. So I think that I don't know how I'm going to do, even if I just have optic neuritis. And usually if you have that without any other motor or sensory problems and very little on the MRI, you're going to do well. Well, I've seen people with very little at the beginning have very bad outcomes and vice versa, who started out with a firestorm and then kind of quieted it down. So that's also maybe a reason why I can't predict whether I'm going to be good or bad. So I'm going to take the insurance policy and I'm going to do what I can to stop any bad things from happening. We know there's more atrophy of the brain, more relapses, and more MRI lesions in untreated patients compared to treated patients. There are an abundance of studies that have shown that. And benign MS is something that was touted as occurring 5 to 10% of the time. And maybe it's not so benign. And then I think another reason one would not want to have regrets. Well, I did what I could to stop this. I didn't just play passive. So those would be, I think, pro comments that people would have. Well, early relapses have been associated with a conversion to secondary progressive MS over 28 years. So the more relapses a person has early, the more likely they're going to convert to secondary progressive MS. And here it would be 3 attacks versus 1 attack. The incidence of going to secondary progressive is much higher. MRI lesions in the first year of therapy, so new MRI lesions in the first year of therapy predict worse outcomes over time. And there are a couple different ways to look at that. Relapses in the first year and MRI lesion load over time. People who didn't have one had much less accumulation over the same period of time as a person who had a relapse, or had an MRI lesion, sorry. So here's the benign MS. So benign MS was defined as having a disability scale score of less than 3 at least 10 years after the diagnosis of MS. So if you've gone 10 years and you still haven't reached a disability score of 10, and there are other definitions as well, things seem to be very, very stable. Well, you have benign MS. It's predicted that you're maybe not going to have any more issues to occur, and maybe 5 to 10% of people might fit that criteria. But cognition was not studied, and when it was studied in the largest cohort of patients with benign MS, there were significant problems. So as you can see here, depression in that cohort, 47%. You had fatigue at a high rate, MRI changes at a high rate, and then other neurocognitive abnormalities were much higher in the quote-unquote benign MS patients than matched subjects. So, is there a window of opportunity as well? So I'm just going to go through a couple of studies just to highlight that brain atrophy occurs from the get-go. And it seems in an untreated individual that brain atrophy occurs at the same rate as it does later in MS. So that would be an argument to treat early. A certain group, Karasiti, painstakingly dissected autopsied brains and did a neuron count. Blinded to who had MS and who didn't. And 40% less brain neurons in the MS patients compared to age, race, sex matched individuals at autopsy. So you lose 40% of your neurons. That would say, boy, I want to do something to keep that number down. And then the regenerative potential of the brain becomes less over time. So the brain doesn't have as gifted remyelination abilities necessarily over time. And you have less reserve. In a recent secondary progressive MS study with saponamide, which showed benefit in secondary progressive MS, it showed benefit as long as the patient had 10 years of MS or less. So disease duration seemed to matter. The longer it went on, the less likely medication was effective. And we know that relapses early are very predictive of long-term outcomes, but relapses later don't seem to have very much correlation with long-term outcomes. So is there a window of opportunity that we miss if we don't treat early? We had a very good talk just before mine about these exact issues right here. And why? Because those issues are very common in people with MS. So processing speed and focused and selective attention are the 2 greatest portions of the brain that are affected in MS. You also have episodic memory, decision-making, and visuospatial orientation problems in MS that are very common. And as was stated eloquently before me, word anomia, can't find the right word, or paraphasic errors, the wrong word comes out. Thought blocking, you're talking and then all of a sudden it vanishes, are very commonly seen in clinic. And cognitive dysfunction, depression, fatigue, pain all kind of change as the day goes over. So as the day goes on, all of them increase in impact in a given individual, but it's variable from one day to the next. So trying to make a plan, yes, I'll go to the park tomorrow. Well, tomorrow is a day when they kind of advanced pretty quickly. Very frustrating and unpredictable and unsettling for someone with MS. The unpredictability of how those symptoms vary in a given day. Also, cognitive decline starts even in RIS. So Amato and his group showed that the cognitive difficulties start even when just the brain looks abnormal, but a person's functioning without any relapses. And another really intriguing study that I hadn't seen in preparing for this talk was a study that looked at people with MS and looked at their school performance 5 to 10 years earlier and saw that it was subpar. And it was statistically significant in their analysis. So maybe the cognitive effects were occurring prior to any relapse or knowledge of MS. And the number one reason for disability or lack of employment or loss of employment is cognition. And fatigue plays very well with cognition. So fatigue kind of works on attention, which then, as you heard, doesn't allow you to remember things very well or function very well. So permanent change, people who went on a therapy, an MS therapy early, compared to people who were on a placebo arm and then started medicine 2 years later, the people who started on placebo and then went to medicine, 46% greater mortality rate in the people who delayed 2 years the onset of their treatment. And we have an abundance of studies that show people who are in a placebo arm or in the weaker medication treatment arm over time never catch up statistically to the group that was treated more effectively early. So all those, I would say, are really good reasons to start early. And here's this depiction of patients who died at a much higher rate if they started on placebo compared to starting on medication. So axonal damage also occurs early and occurs at a great rate early. So all of these are kind of the same message. This is Dr. Krieger's work. This is really very interesting and I think neat to look at. So if you want something fun to do on a rainy Sunday, look up Dr. Krieger's model here. It's really very neat that over time, when you lessen your brain reserve, those areas of damage surface and you feel them more. So if you have less brain reserve, you're going to feel relapses more over time. And there are certain parts, like here the optic nerve or the spinal cord, they're very small structures. So damage there, you don't have a lot of reserve. If you damage one of the structures, you're likely going to be symptomatic either this time or the next one you have there. Whereas way out in the cerebral hemisphere, you got a deep ocean, you have a lot of reserve, so you can take a few hits out there and still function rather well. But over time, the more hits you have, the more reserve you lose. That's a very interesting model. And we know if we wait several years, so the original injectable medications that we had, they typically were utilized 6 to 8 years into the diagnosis. And patients had about a third reduction in their relapses. And the severity of relapses were less. Thank the good Lord, because we had those medications approved then. And then we started moving forward with treatments. But that's not what we don't want to just make you sick less faster, right? We want to shut it down. So we don't want to wait 6 to 8 years and have a okay response, something that's better than doing nothing. So we want to diagnose and treat earlier so that the impact on you is much less. This would just be one study that showed patients who were on the higher dose of medication had less disability over time, and the people who were switched over to the stronger medicine never caught up, never reached the same benefits. Each new lesion, as you can see here, has a significant greater impact on suboptimal response over time. So each new lesion that we allow to happen is going to make you less responsive to treatment and less able to function at a more normal level. So I'm going to kind of beat that message to death, I think. So no matter how you slice it, atrophy, brain shrinkage, axons. So then what do we do, with all that information? So let's say we look at treatments. What treatment options do we have? Well, we can treat symptoms. We can treat relapses. We can control disease better than not using anything. And then I have some other things. So symptom management really dominates our visits in clinic. It's all about how can we improve quality of life. As long as we're on a good DMT that's kind of controlling your disease, it's all about How can we manage your fatigue, your depression, sleeping, spasticity, bowel bladder difficulties, all of those things? That's really what dominates our conversations nowadays. It's the symptom management of the baggage that you already accumulated. So these are some of the things that we treat. And then, of course, as the first speaker said, exercise is very important. I mean, the better health you're in, the better you're going to handle whatever comes your way, and your outcomes are going to be better all the way around. Paying attention to diet. There's not any diet, and I know he talked about that. I don't think we'll ever have a diet because people are on so many different things that you can't control the variables to say that this diet is better than that diet. I think in general, less carbohydrates are good because carbohydrates are complex sugars that take a lot of energy to metabolize, and you already have a fatigue deficit, and then they get stored as fat. So less carbs generally we think at this day and age is better. Smoking impacts your genetic susceptibility to relapses and getting MS in the first place. And we can't forget that those with MS have the same risk of heart disease over time and other things, and we focus so much on MS, we forget all the maintenance things we need to be doing. So we have to be mindful of general health as well. Now, relapses. This is a study by Lublin, and that's a study by Hurst. And they basically say the same thing, that after a relapse, about 30% of people have a 1 point out of a 10-point disability scale permanent change, and about 40 to 50% of people have a half-point change. You're never going to be the same again. And it may be subtle, half point, but I don't want to be never the same again, so I don't want to relapse. I don't want to take a chance, right? So relapses aren't just some also casual thing that you treat, get over, and that's it. Relapses, the number early predicts long-term disability. Plus, each relapse gives you a real possibility of not functioning the same again. There's no uniformity of treatment, though. We don't have any, there's no one center, next center, there's no guidelines or no systematic study of how do you best treat a relapse. And it's like Baskin and Robbins. You can go to 5 neurology clinics here in Birmingham. You'll be treated differently at every single one of them. Be treated differently at mine and everybody else's. So we don't do a very good job of treating relapses. And we have really good, medications acutely to stop the swelling. But then we need to monitor progress. Because if the follow-up's 3 months from now, and steroids or whatever, Acthar or whatever you used helped your relapse, but then so I hear this a lot, my arm got better, but then a week later it came back again, it got worse again. Well, that's because the medicine, when it was lowered, did not handle the inflammation as well. We needed to keep it up a little bit higher, a little bit longer. And you come back 3 months, inflammation's gone, you have a permanent scar. Not a lot we can do about that right now. So we need to have a program in place that if you're not better in a week, you have a relapse, you're not better in a week, you need to call the office because we need to figure out whether we need to start with a different treatment. Number 2, if you initially are better and then worsen, you need to let us know because what we were doing seemed to be working initially and now it's too low and we need to do something to regain control over that. And 3 is have a follow-up at a decent period of time. And for us, it's about 6 weeks to make sure that you're back to where you were before the relapse or real close. Because if not, we need to know if there's still inflammation that we can get rid of or something we can do to get you back to that baseline. But waiting 3-4 months is not really the best way to treat a relapse, in my opinion. When we choose a therapy for relapsing remitting MS, I've said this since 2000. So this was my lecture in 2000, home run of therapy. What do we want out of our treatment? Well, we want it to be well tolerated and safe. We don't want to feel lousy a day or 2 a week for the rest of time. And we don't want to take something recklessly. We don't want any relapses. We don't want any worsening of our neurological exam in clinic. And we don't want any new lesions on our MRI scan. And I think if we achieve that, we're probably on a very good disease-modifying therapy. And if we're not reaching these goals, we need to be thinking about changing what we're doing. At least we should talk about it. And I'm going to kind of skip through. NEDA came out of this, and it was just kind of a separate group that kind of decided in the mid to late 2000s, about 2008 or 9, that NEDA, hey, NEDA is a good thing. No relapses, no disability progression, and no new MRI lesions. So that now has become kind of buzzwords and what we're looking for in our treatments across the country. So NEDA is what we strive for. And why? Because in one instance, NEDA at 2 years, if a person has had no progression, no signs of MS, either on an MRI or physically, at 2 years after a treatment, they're free of progression at 7 years at a pretty high percentage. So if we can gain control in the first 2 years or over a 2-year period of time, and you follow the rules and continue to take your medicine, and I follow the rules and evaluate you appropriately, our chances of doing well is very high. There are certain things that allow us to make decisions. So decision making between the clinician and the patient and caregivers, there are some things that we know. If you have a high lesion load early on, that's going to predict maybe a more disabling pathway. So maybe the medicine we choose is a little stronger, maybe with a little bit more side effects, but the risk of having MS significantly affect you is higher. We know that lesion burden over 5 years predicts worse long-term outcomes. So even if you're physically exactly the same and you have a large burden of MRI accumulate over time, which can happen because 9 out of every 10 MRI lesions don't cause symptoms. So if you have a higher burden accumulate over a period of time, you're predicted to do much worse in the long haul, as Joe next to you, is exactly the same as you right now, but had less lesions accumulate. So maybe we need to do something different in you than we do in Joe. And here's one of several different ways for us to try to say who's at highest risk? Who needs that really big gun early on? Well, we would say someone who's male, African American, multifocal presentation, blind in an eye and weak on the right side. Not just weak, not just numb, but multiple different things at the attack. High lesion burden initially on the MRI scan. So I didn't say women don't need to be treated aggressively. Okay, don't take it that. But males seem to have a course that predicts that it's going to go worse, more because progressive MS is higher incidence, and that's a harder thing to treat. So these are just things for us to think about, to say if we're having some of these issues, we need to really watch closely and treat aggressively if at all possible. So shared decision making, we kind of have our idea of what we're thinking about in a given individual. So this is me. I want to know, is the medicine, is it efficacious? Does it cut down your relapse rate? Will it help your disability from going forward? How is its impact on an MRI scan from the clinical trials in my experience? What kind of challenges do we have both to start the medicine and to maintain a medication? And what are the safety and tolerability issues? So I think about all these things when I'm talking with you about a particular treatment. Now, we may not talk about all these things, but I'm thinking about these things in given individuals, knowing who's more likely to have this and that, and how the presentation was and how it's going to course. So that's what I bring to the table when we're talking about medication. And then you have your things that you bring to the table. My lifestyle, demographics, can I have refrigerated medicines or not? Can I go to a clinic every so often to get IV infusions, or that just doesn't work because I have to take time off from work and chew up all my vacation days? Or you have a lot of things on your plate too, and what you're willing to take on as a risk. So that's shared decision making. I bring what I do, you bring what you know, and we try to put them together and come up with what's right for you. Now, some people abdicate that responsibility, and they say, you're the doctor, you have experience, I'm going to give it to you. And that's done with chemotherapy a lot of times, in cancer or epilepsy. People don't make those decisions, so that's perfectly fine. But we want to offer the opportunity for your input on how you think this is going to go and how you're comfortable with things. Because it may be a very low risk, but you're not comfortable with that, and that's important. We would love to have evidence for everything we do, but we don't. And unfortunately, insurers generally and some other kind of rigid clinics and facilities really can't function if there's no evidence for it. It makes it a lot easier to follow the rules, and when an individual's outside of that, you still have to follow the rules. So we would love for to have that information to know what we're doing is evidence-based on everything, but that's not always the case. So we have to be kind of humane as well. And I love this quote. It's kind of ancient, 1892. Sir William Osler, very famous clinician in the past, said if it weren't for the great variability of individuals, medicine might as well be a science and not an art. And that still holds today. The more we know we don't know. Right, as you can see on some of those pathophysiology things, we're learning more and didn't know that this happened and that happened. But we have to work with an individual before us, and that's where clinical experience comes in, and trial and error, and working with somebody and going forth. You can't just put a square in a round hole all the time, right? Everybody doesn't fit in that round hole. And where does the evidence come from? We also have to remember that. So we tout the evidence, but the evidence comes from clinical trials, and clinical trials excludes a lot of people from participation. Very clean. Age, certain age, can't have diabetes, out of control, hypertension, this, that, whatever. Well, guess what? People with MS have some of those things, and they weren't tested in the trials. So maybe the evidence from the trial doesn't really fit in the situation, and we think maybe that's not the right medication. So that evidence that's required sometimes isn't really evidence for the person right in front of us. And when you hear talks that are pharmaceutical-based, you're going to hear what the FDA allows you to hear, right? Which is fine. It's promotional, and they don't want people giving information that may be accurate but kind of skewed, and so on and so forth. But you have to know that, because there are really important things that are available that aren't in the label that are really very trustworthy and happen. So here's an example. So let's say we do an MS trial, and the primary endpoint is, do we cut down the annualized relapse rate, which is the primary endpoint in many clinical trials. Does this medicine cut down the relapses better than this one on an annual basis statistically? And then the company comes with secondary endpoints. Okay, well, the secondary endpoint will be time to a relapse. It took 555 days for for the population to have a relapse on this treatment, and it only took 300 for the population on this. We want the one that delays people to have relapses. T2 lesion volume, the number of lesions on your MRI scan cumulatively, the number of new T2 lesions, and then tertiary endpoints, enhancing lesions, quality of life, reduction in disability. These are all preset before the trial starts. So the company has to kind of guess. We're thinking that these are going to be endpoints that we want to look at and we think we're going to be favorable with. Because what happens in these trials is, once one of those endpoints is not met, that company is not allowed to speak about any of the other ones below, even if they were markedly statistically beneficial. So it's just a random act of how it was chosen, and once you hit one that didn't meet significance, everything below that cannot be discussed, cannot be put in print in your package inserts, and can't be at a pharmaceutical talk. So I love these talks. I love Stuart for having these talks, because I can say what I want to say up here. I'm not bound to, and I really shouldn't be. I should have freedom of speech. But you need to know that, because you're going just with, oh, that's all your information set. You don't know that that's not the full information set. And this happens in some treatments where they just pick the wrong outcome, and every single MRI outcome was markedly beneficial below, and that was the only one that didn't, but they placed it the highest. Whereas if they had just chosen the other ones, they would have been able to put that out in print, and you would have heard about it all. Doesn't seem very logical or good. So we're left kind of scratching our heads sometimes, right? Now, just a couple other pearls. How am I on time, Stuart? Okay, all right. All right, so the fundamental, what's a doctor-patient relation? The fundamental part of that is our interaction. That's what it's all about. That's why it all exists, is you have something going on, and I hopefully have some kind of solution or comfort or something that we can do to make life better. But there are problems to that relationship now. You know, in the olden days, you know, John Boy would have the doctor come out and he would take a chicken and everything would be good, and that's how it worked. That's how that interaction worked. Now we have insurance companies, and now we have pharmaceutical companies. And they both have virtues, but there are also some problems, right? So access to care, access to medication that costs so much, right? It's restrictive. Medicare. I don't know. My blood pressure will go up if I talk about Medicare too much, all right? Because patients can, you know, Medicare covers 80% of things. That leaves 20% of very expensive cognitive testing or MRIs or medication. You know, that's not that's a chunk of change, right? And the government won't allow assistance, coupons, write-offs, or assistance from the pharmaceutical companies to help offset that cost, because it's maybe an inducement to use that product. But they can do that with every commercially insured patient. And people on Medicare generally are ones that have a little tighter pocketbook, right? Not so full, right? They need the help. So it's very frustrating. So that interferes with that relationship that we have. And then on the clinician side, if we don't use what some pharmacist or PharmD through the insurance company says is most appropriate, we can't get it, right? Even though there are so many nuances to the individual who has depression or anxiety, sleep disorder, atrophy in the brain here, there, and there, that isn't even in their thinking of saying what medicine you should have. But we get dinged if we use non-generic medications or we do this and that. So we have a lot of pressure to restrict treatment to you, which we don't think is the best treatment necessarily. We pick the best agent that you can afford and will do the best job given the circumstance. But most of the time isn't the medicine we would choose or the treatment modality we would choose. So that really interferes. That's a barrier to the fundamental relationship. Now, two last things Stuart wanted me to talk about, and you can see how extensive this slide is. Comprehensive healthcare team in MS. Well, it can be as grand or as small as is possible, as is your environment and your location. I would love to have a speech cognitive person right next door who would get paid for his or her services and render good service to you, and you didn't have to pay out of pocket anything too exorbitant. I would love for that to be. That's not generally, thank you. That's generally not available in a lot of places. So the Tanner Center is very fortunate to have Kathleen there, who I know does a very good job. But that's not always available. Urologists, you know, for bladder control issues, and physical therapists, occupational therapists. Those are parts of the healthcare team. Mental health specialists would be a part of a comprehensive healthcare team. And so anybody who really takes care of aspects of MS should be on board in knowing something about MS and working together as a team to take care of the different problems. One begets another, et cetera. I guess I'm supposed to do this. Thank you for the effort. And then the download, just kind of some random things. So MRIs, how often should you get them? The recommendation is yearly, and I think that's rather appropriate. A yearly brain exam is a good idea. New lesions occur without symptoms 90% of the time. The brain accumulates those 90% of the time. So those are two different 90%. Most of the asymptomatic new lesions that occur in the brain. So that's why we use the brain. Even though you may have had lesions in the spinal cord before, if you're not having anything new referable to the spinal cord, then we may not image that but every 3 or 4 times just to look and make sure you don't have a silent lesion there. What kind of scan? Well, if you go to open scan, well, it's nice, and boy, I have a lot of room in there and things are grand, but it's only 1/10 of the strength of a real good closed one. So you get what you get, right? So if you get a roomy one that's not very concentrated, we don't see very much. We don't see nearly what we see on a stronger one. where to image. Like I mentioned before, spinal cord, if it's bilateral symptoms or something referable to the spinal cord. Most lesions are in what we call the non-specific area of the brain. And I really, this would be one of my projects if I had more time, would be to really explore this, because the lesions that occur in that non-specific area are important, and most of the active new lesions occur in that area. But people who have lesions in that area predominantly are not diagnosed with MS because they say that's not in the typical MS areas, which are right around the ventricles, way outside in the brainstem or spinal cord. They're in between. And yes, they're non-specific. They can be due to other things, but they're very common in MS. So a person with MS is not diagnosed with MS because they don't have the classic MRI image. And yet, if you go to pathology lab, most of the lesions are in that non-specific area in people with MS. So there's sort of a disconnect there. And people are told they have migraines or hardening of the arteries at 30 years of age. That's why you have 7 white matter non-specific lesions or something along those lines. And that's just, unfortunately, not accurate and proves to be different over time. Now, we have to be wary of placebo and testimonials. So you go to the internet and, whoa, this person was cured of their MS. They did this, and it worked, and they did great. That must be something really good for MS. There's something called the placebo effect, where people get better. I mean, it's not a sham. It's not anything phony. People who take something that doesn't have, like an inert substance, and get better, they are better. Their physical function is better. Their diabetes is controlled. Their cancer is in remission. Their hypertension is better. Their MS relapses have quieted down. It's a real thing. The danger is when we attribute whatever was given to be the reason why. Okay? The power of the brain and thinking. So Dr. Wall's diet, for example, her diet may be very effective in MS. We don't know. It's one person's story, very good story. She had a great, I'm glad for her, she had a great outcome, and she's doing much better. And I hope it's due to the diet. But I can't professionally go out and espouse the diet, because we haven't tested it in different populations to prove that it was the diet that led to her improvement. So we run a danger. It's not that we're against alternative treatments. It's that we don't have real good proof to say absolutely that works. CCSVI, or we help dilate veins, that sort of proved not to be effective in several different areas, but initially had a lot of fervor. Essential oils, they have a lot of positive outcomes, but to treat MS and change MS, I don't think we're there yet. So it doesn't mean don't use them. And typically when people ask me, should I do the Wall's diet, I say, I can't tell you if it helps or it hurts or it's nothing. I just can't give you an educated answer because it wasn't tested that way. And hopefully with these things I can say, it's not likely going to hurt, so you have my blessing, which I try to do. But just be careful of those great things. Like Walter Cronkite came on the news. My mom was looking at it and goes, hyperbaric oxygen, the new cure for MS. People have done well. And it failed at that time. Now there's new hyperbaric oxygen, and maybe it works now, but back then how it was, some people seemed to respond, and it then failed, so it was a failed thing. But just be careful of those blockbuster news things that, yes, we want to be encouraged and hopeful, but just have a little bit of caution and let time tell us whether that's right or not. Package inserts, those things that you get in the boxes that are about this long and say you can die or gamble or do this or that, that's just a list of things that happened during the studies. There's no correlation. It's just a list of things. So if you had, let's say, 3 of your family members had the flu, you were in the clinical trial, you caught the flu is going to be listed as a side effect of that medication, or listed on that list. Likely that medicine had nothing to do with you acquiring the flu, right? So you have to be careful in looking at that and saying, oh, I don't want to die, I don't want to have this, I don't want to have that. Well, that's just those. I don't want you to either. But that list doesn't mean that it correlates to the risk. So the higher the difference between placebo, then the more likely that medicine is causative, right, of that side effect. And sometimes insurance will use that list although it's not a correlative list, so we have to be mindful of that. And then expected cancer. So if you're in a clinical trial and one person develops cancer over 3 years, say a 50-year-old female has breast cancer, and there were 1,500 women in the trial, and one woman unfortunately had breast cancer over that period of time, it would have to be listed as possibly related to the medication, which I think is appropriate. But that's different than saying it's a high risk of you developing cancer because of that. So just because it's listed as may cause cancer doesn't mean that there's any correlation or any shred of evidence that that medicine does that. We have to be very careful about just taking that as the absolute, all right? Because, for example, one of our MS medications, there were over a period of 5 to 6 years, there were expected to be 146 cancers over that time, and there were only 31. That's an 80% reduction. And what's in that list may cause cancer, right? Because there wasn't a pre-planned look at cancer, so the company can't say anything about that, nor really should they, because it really wasn't proven to be reductive of cancer. It wasn't designed that way, and maybe it is. But on the opposite, it shouldn't say, as the only qualifying statement, may cause cancer. Because I've had several patients where we talked about the medication initially, and I didn't mention that because it was actually a reduction, and they say, well, I really don't want to take that product. And I said, what's changed since we had our clinic visit? Well, that may cause cancer thing. And then we have to have that discussion. And then if one still has discomfort, obviously we don't go on with that medication. But we just have to be careful about absolutes in those package inserts and other things. And I hear often cure or fix. When's the cure coming? Cure is different than fix. If you take something and you don't have any more disease from here forward and you don't have to take that medicine anymore, that's a cure. It doesn't mean that it brings back your function. That's a fix. So something to remyelinate and restore function, that's a fix. Something that you take for a period of time, then don't have to take it anymore. Let's say chemotherapy for breast cancer. It doesn't bring the breast back, but if you haven't had any more cancer in 5 years, the oncologist is doing a happy dance, and you are too. You're expected to be cancer-free. You're cured of cancer, right? Last few, I promise. So practical points. If you're smoking, find ways to stop smoking. It is a risk. It's been shown to be a risk for relapses and worsening disease. Exercise, you had that great talk to begin with. Take it slow. It's not about getting there tomorrow. It's about getting there and staying there. So don't get disillusioned from being too sore and doing too much right from the get-go. Vitamin D you get from UV exposure, and UV exposure actually has other anti-inflammatory effects. The sunlight does better than just give you vitamin D. It has other positive effects. So 10 minutes in this time of the year, April to October down here, short sleeve shorts, should get your vitamin D level up and give you some exposure to UV without overheating you, hopefully. Look into cooling vests. The MSAA gives out free cooling vests every year to people with MS. So a lot of my patients don't know that, but down here, that can really allow them to go to an event that's really important for family or friends. I talked about the diet. An educated family is really helpful, so having them come to the visit or come to these programs, and thank you all for caregivers who came to be educated, that's really, really important. You speak on the same language. Spirituality, if that's something that's important to you, that's something that certainly you want to strengthen. There was an individual who died this week who had a rich life, and he would meet with military people who came back and they were injured. They were permanently injured. And he himself had had a diving accident at age 21 in a pool, and he was paralyzed from then on. And he said, I first had to acknowledge that I'm never going to be that way again. My physical function is never going to be that way. And then I'm going on with life. That's a given. I accept that. Now I am going to enrich my education and went on to be a psychiatrist. And I'm going to work on my spirituality. I'm going to strengthen the things I do have as strengths, because we all have strengths and weaknesses. He just had his physical ability in a lot of ways taken away. So he just said, that's I'm not going to dwell on that. I'm going to strengthen the things I can strengthen, right? And so his perspective was that way. So spirituality in your walk can really, is there anything more important than that? So, work on that issue, which can help you in a lot of other ways. We have future challenges, which I won't talk about. Remember this conditions, it can slip up on you, and you have a bad relapse, you may be permanently changed, so don't get sloppy with your treatments or follow-up visits, etc. Hold a very high bar of success for your treatment. One relapse, few new lesions, that's not acceptable. We need to talk about it. And maybe we stay on the same course, but that's not acceptable to just slough off. We need to follow up diligently after relapses and treat them aggressively, or we're going to have permanent changes. And then and this slide's for me, we need to treat you as if we had the symptoms. If I had depression or anxiety, I can just say, well, just kind of work on that. That's not good enough, right? So we need to treat you as we would treat ourselves or our family, and that's a common cliche in doctor language, but we really do. We really need to say, well, what would my quality? We need to be very empathic. What would my quality of life be like if I'm tired by noon and I can't do very much? Do we just ignore the fatigue and say, just hang in there? We need to be champions for you. And each person's an individual, not fit in one type of box. If you lose insurance, there's a lot of help out there. So I have probably one or two patients every year comes in, they haven't been in for a few years, and they say, well, I couldn't come back because I lost my insurance. It's like we could have given them free medication and could have gotten an MRI every 2 years for free and could have done this and done that, and we take good faith payments and so on and so forth. It doesn't mean stop. So if that ever befalls you unexpectedly, don't drop out. Right? There's a lot of resources and help out there. Last thing I'd say is false burden bearing. I hear this in clinic many, many times. So I'm a burden. I'm a burden to I just hate that I'm a burden to my husband or to my wife or to my family. I feel, and so you kind of withdraw. Well, and then I ask them usually, I say, well, what if your husband was in your shape and you had to take care of him? He'd be a burden to you, right? And they go, oh, no, he wouldn't be a burden to me. Oh, so you're better than he is because you can take it and he can't take it, or she, and vice versa, whichever sex you wish to mention. But that's the arrogance of illness, is what I say. I say, no, if you think that for better, for worse, and sickness and health is true, and you would honor that, he or she's going to honor that, right? And you're not a burden. We don't know what's going to happen. We bond this relationship forever, right? So it's not a burden. It's actually what I would say is a blessing. Okay, when he or she helps you into the car, is it better to do for yourself or do for others? I've always taught do for others. And I think the good book says that too. So if you have a problem getting in the car and I help you, you've blessed me. I've done something for someone else, right? That's a blessing, not a burden. That's how we need to look at it. We're helping someone who needs some help. That's always a good thing. And that's what I would leave. It's more blessed to give than to receive. So if you have the problem, don't feel like you're a burden. You're not. Things are different. No one can predict things. You didn't go out and shoot up drugs, have indiscriminate sex, and have this condition as a consequence. This was something you didn't have any control over, so we go with it, right? Don't feel like you're a burden. That would be the last thing I'd say. Thank you very much.
Thank you.
Oh, yeah, I'm going to ask a question. Oh, that's, yeah, okay, very good.
Anybody got a question? Here we go.
How do you spell the Krieger study? How do you spell Krieger?
Krieger, Stephen Krieger.
Say it again.
I think it's Ieger. I before E except in. Oh, sorry. Krieger. Krieger or Eiger.
He's on our website also, so you can find
Stephen's
him there
his
too.
first name.
Right. Mm-hmm. Right. Any questions? Any questions? I got questions if you don't have questions.
We got one right here.
If I understood you correctly, earlier in your speech, you were talking about how stress may affect MS. I had a friend tell me that, and the reason I'm interested in knowing about that is that my mom was diagnosed within a year of her mother passing away, and since my dad has passed away, her symptoms have gotten worse as well. So I just wanted to clarify that, I guess.
Yeah, so more likely than not, the worsening is due to the stress on the body. That those areas that are already damaged from before are functioning at a certain level and able to maintain. But then when you add stress to it, they don't put out as well, okay? And death and grieving and those certainly, and changes and having to sell the house or do this or there's a whole lot more than just the loss of a loved one. There's a lot of other issues that are stressful at that time too. And so there's a lot of stress at that time. I had 3 this week who had similar type things. Parents passed or spouse passed. So that's one of the greater stresses we experience. So I would expect a person's MS to function a little worse during that time. Now, if it's something that they had never experienced before, a different neurological problem, let's say the left side became weak and it never had before, then I'd be concerned that there was new disease causing that to happen. And I would probably take a picture and make sure that we were identifying new problems. But if it's old lesions causing the problem, you don't need to take those lovely steroids because there's not inflammation that's going to be taken away. Rather, we need to try to help stress. And there's modifiable stress and non-modifiable stress. Death of a loved one, that's not modifiable. It happened. And so you work as best you can to get through that issue. But over-volunteering at the church or the local center, that's a stress that you can work on. So they're good endeavors. A lot of times people overextend themselves with very good positive things, but it's too much for their system. And they fatigue out, their balance gets worse. Other things happen, and they need to really restrict to the most important and prioritize the things that they're doing. That's modifiable. Hanging around people who are negative all the time, that's modifiable usually. I'm not going to go there because every time I go away, I feel worse and my walking gets worse. That's a stress that's modifiable. Going out in the heat of the day, that's a modifiable stress. So it'd be like having a chair that's kind of wobbly legs, and it stands there without any weight on it. You put 5 pounds on it, it's doing okay. You put 25 pounds on it, crashes down. So it's just that weakened areas aren't able to hold up during the stress. So that's what I'm talking about, that you're going to see a decline in function. Doesn't mean that you're worse, your function is worse, but the lesions aren't getting any bigger or wearing out any more. You're developing new ones. It's just that the ones that you already have already been working at full capacity, and they can't handle the extra energy load. Okay.
Before we go to the next question, for anybody that's been taking notes all day, remember this is being video recorded, and we're going to send out an email to you to let you know when it is published, but it will be about 6 weeks before we get to it, because that's how far behind I am, going back to April of getting things published still. Next question.
Okay. Hello, Dr. LaGanke. How are you doing? Good seeing you. How do I get to your clinic?
I'll talk to you after about that.
We need to. But I'm going to start on Limtrado. So, anyway, I don't know if anyone's spoken about this. They're talking about a new drug or something like that comes from marijuana. It's an oral drug. Are you familiar with that?
I think if it's CBD,
Have they already talked?
that's probably what you're referring to. That's very hot in the news lately. So there are different parts of the marijuana plant. There's THC, and then there's a cannabinoid part. And we in this state have been granted the privilege to write for cannabinoids, but the state's not privileged to dispense it. So the first step was made in the process where they passed legislation that way. And if the state grants the ability to dispense it, then we can distribute that or prescribe it as is appropriate. CBD has had very positive effects in epilepsy, some in Parkinson's, in pain and tremor and appetite, and in MS it has some quality of life benefits. Now, if people have a lot of cognitive problems, there was a study presented in Paris that I went to in November that said that if people had a baseline cognitive score that was pretty low, they actually worsened over time taking the treatment, and people who didn't function better neurologically, so their motor scores were better, their spasticity was better. But if there's a baseline significant cognitive problem, you have to be careful. It doesn't mean you can't, but you have to be very careful and mindful of that. There's a lot of news, and people can get some CBD oil here in local natural stores of very low concentration and amount, less than what we would prescribe if we were going to utilize it. But some people have found benefit with that already. As far as disease modification, there's not real great evidence that taking that's going to ultimately significantly change your course of the MS lesions, but the quality of life is significantly beneficial in a number of people. There's a lot of information on that. In fact, Stu's website, this latest newsletter, I do look at it this week, had a bit on and a link to cannabinoids.
There's the CBD oil that is out there is very, very, very decaffeinated coffee, all right? There's
Very
only
low.
trace
It's
of
very low.
THC, and it is legal in all the states of the U.S.
Yeah, that
all right?
is. But at the strength we would prescribe, that's not available.
Right.
Now, Marinol, which is synthetic THC, is available. I've written for it for years, and that's a different portion of it, which helps with pain and spasticity, and is something that is available for us to write for if it's appropriate.
I'm sorry I didn't follow when she was asking about my case in particular. Okay, it's been a little over 2 years since my husband passed, and I'm not happy about it, but I'm dealing with it, you know. But what did you say about what I should do? Should I be getting to find out what do I need to do?
Well, in general, so I don't know your case and everything, you know, to give you direct medical advice, but in general, if you have worsened directly related to a significant stress, it's probably the stress that does that. If it's continuing on and on, well past that stress, and you don't think that that likely is having much to do with it, then you should be evaluated for why you're worse. So that can be a whole lot of different reasons for that other than the stress that may have started things to go downhill. But I would say that if that you're dealing with it and you've grieved appropriately and you feel like you're in a stable place, but your function continues to decline, then you need to have that evaluated. I wouldn't attribute it to the stress anymore. I think your neurologist is a good start if you're neurologically worse, and then if they think that they don't, if the neurologist doesn't believe that they have a good, adequate explanation and want to make sure there's no medical problem that's underlying that's aggravating it, then they would probably send you back to your internist or primary care physician. But the person who knows you best is probably the place to start.
Okay, relapses. Are there any other treatments for relapses other than steroids?
Yes, so steroids has been the mainstay for a long time, but they don't work in everybody, and they have some side effects that are untenable for some people. So ACTH or Acthar gel is something that can be very helpful. Some people use IVIG if both of those aren't helpful, and that can be helpful in some people with inflammation. But typically it starts with steroids, and then it generally goes to ACTH, and then goes from there.
Can you write a prescription for the cannabis?
I can write it, but you can't fill it. Now, the FDA, I will say, the FDA about a month ago endorsed cannabinoids and said that that would likely be a good thing to have available. So that, I think, is going to speed along that process immensely, because if the FDA gives the endorsement, then states won't feel, a pull on that. So.
Other than MRI as a biomarker, what else might you have coming?
Yeah, that's the golden or the holy grail, I guess. We'd love to have a non-invasive biomarker where you don't have to get crammed in a tube and stuck with an IV and dye put in. It's for us to monitor how well treatment is going or how your course is going. There are neurofilaments in the neurofilaments that seem to maybe be predictive of how a person's MS is going to go. But right now, that's from a spinal tap, so that's not really helping the invasive issue very much. But there seems to be some really good correlations with neurofilament levels and treatment response. And there is a test for MS now, and I'm not endorsing the test for MS, but there is an RNA test that's now available. And I wouldn't say that it's 100% one way or the other, but it's available. And to answer your question, it's being looked at as, does the level change if a person gets on an effective treatment? So that would be a biomarker of treatment response if it holds up as being something valuable. So that would be just a simple blood test to do that. But other than that, I don't know of anything else on the horizon right now.
I was going to ask you to speak about that. You got me. Any other questions? Great.
Is there no fix for MS? I've seen where some people are fixed. Dr. Swank maybe is one that's been fixed. I think Jeff Siegel was fixed of the MS, and we saw him earlier. 10 years ago, he was in a wheelchair.
Well, some people markedly improve. I mean, from in the bed to full function, and they're not necessarily fixed. They're definitely improved, and whether that's going to stay or not, that's to be determined. So I guess you can only say that post-mortem that they were fixed. But there are 7 different treatments in human studies now to fix MS, to remyelinate. They worked in the animal models of MS, and now they're in human studies. So we're really encouraged to have that many different products being looked at to try to help repair some of the myelin. I would honestly say that I don't think any of them is dynamite as far as everybody's going to have everything fixed. But we need to go through those studies. We learn a lot from the studies to tailor or tweak a medication this way or that way. So we are desperately looking for the fix and the remyelinating treatment.
By the way, I'm going to get back to you in a second. 11 years ago, I was barely walking, all right? I'm not going to say what medication I'm on because I'm not allowed to do that, all right? But 11 years ago, I was barely walking. And I did get onto a medication that does work for me, all right? And it definitely doesn't work for everybody because then that would be the only one out there. But to live my life the way I wanted to live, I just had to teach MS to live with me or get the blank out of here, all right? You know, that's the bottom line. I just have to keep on doing and doing, and I didn't want to stop my life for this illness. And even when I was not walking, I was still getting around and doing whatever I could do. So that's what I encourage people is just to get out and do something because life is way too short to just say, I'm going to sit on the couch and I'm going to wait.
Yeah, we're adaptable beings. You know, you adapt to the situation. I don't think anybody is where they thought they were going to be 10 years ago. I've yet to find that person. Things change, and we adapt, right?
Yeah, so I think Stuart's fixed. You know, if I look at him, I think he's fixed. He's walking around like there's absolutely nothing wrong. And the the story from Jeff Siegel was, there you are, you have problems with MS, you had a relapse, your right leg's not working. Go out and push yourself, work hard. And your message was, hey, don't go so hard, take it easy.
Maybe that's. I think it's go hard, but do it. Get to a hard place, but do it gradually. Okay, and one answer doesn't fit everybody. I mean, some people who are laid out, you know, bed confined with a terrible relapse in the cord, and you know, they're going to be different than somebody else. But I think you start a little more slow, right? Like Jeff said, if you're fatigued, rest. If you have that pain, you know, don't hard charge that pain. Let it kind of work its way out. And that's kind of what I mean is that get into it gradually, initially to build a habit. Because if you get disillusioned with going out and feeling sore and a half hour you were able to do it today on a Saturday, but the work week is not forgiving, then you don't do it anymore. But if you start out with 5 minutes a day and do that for 2 weeks every single day, and then go to 6 weeks the next, and 7 minutes the next, and 8 minutes the next, then you find that you can make time for that 15 or 30 minutes, whereas initially, life's too crazy for me to put aside 30 minutes, and I'm not going to be able to do 30 minutes because I'm going to be desperately sore if I do that. So that's what I meant by gradual. Not that, keep pushing and that you have a goal, but 6 months there as opposed to 4 weeks there, I would say is a good way for a lot of people. Plus, it's just habit. And the other thing with exercise is find something you like. Because you may be gung-ho, and I'll speak for me without MS who needs to lose weight, and I might get into an exercise and I might do really well, and 6 months later it's like, oh, I got to get on that treadmill again, right? So it's something that I wouldn't enjoy. So I'm going to pick something that I like to do. Maybe I like running or biking or Wii Fit or air boxing or something. So I'm going to pick something I enjoy so that 6 months later, yeah, I'm going to go do my air boxing rather than, oh, I have to do that. So that's what I would say. I think we're pretty well on the same page.
By the way, the exercise that Jeff works with is not to get you to lose weight, although he would love for me to do that too, all right? But it's just to condition your body, to get used to, like what Dr. LaGanke was just saying, to get used to doing something for a few minutes and then let it build up and keep it going. And by the way, Jeff and I were diagnosed 3 months apart 18 years ago, and this is how we're doing, okay?
My question is there a cure for foot drop, or do you just learn how to exercise and build up the strength in your weak leg to make you be able to manage your foot drop better?
Good question. So the foot drop initially, if you have it as a part of a relapse, if we get it really quickly with anti-inflammatories, we sometimes can restore that function. But if you've had a foot drop for a while, we likely don't have a fix for it, but there are a lot of things to modify it. So there are ankle-foot orthotics braces that you can put in to keep your foot from falling down that'll allow you to exercise more. Pool therapy is really good because you're not going to catch it on the ground usually, and you're able to lift it a little bit better in the water, and that can build up your endurance so then you can do better on land. There's a Becker's hip flexor assist device, which helps both lift the leg and bend the ankle up. And there's something called Kyogo, which is only in Canada still. And it's a brace, it's electronic you put on that helps people to walk who have a very difficult time walking. It's not available in the States yet, but I hope it comes soon. But there are devices that can be used. There's a walk aid, which is an electronic device you put around your upper leg, and it has a sensor in the bottom of the foot, and when it senses you lift it, it electronically moves your foot up. So it physiologically moves your foot like it's supposed to. And there's Bionus device as well. So there are 2 electronic devices that can help it. Unfortunately, insurance at this time doesn't cover it and a little pricey. They will take payments, but hopefully that's going to come and that can help offset it. But as far as fixing it, reversing it, right now we don't have that. There's nothing wrong with your leg. It just doesn't work right. So it's like a television that's unplugged. The TV's fine, it's just not working. Your leg is, everything's perfect, it just is missing the connection. So if we somehow could connect here, we could get that foot to go back up. So that's our challenge.
I don't think there's any other questions, so I just want to thank you.
Well, thank
Everybody
you.
want to
Thank you.
Dr.
Thank you
LaGanke?
very much for paying attention.
Awesome. Handshake. Good going. So, again, I want to just thank Sanofi-Genzyme and Celgene for sponsoring this today because, they did a great job. Otherwise, we couldn't have done this for you. And if you could all remember the seminar evaluation forms, if you don't want to fill it out and bring it outside, just leave it on the table, but please do fill them out. We must get these back from you, okay? Or you can give it to that person in the doorway. I want to thank everyone that spoke here today. Jeff Siegel already knows he gets my applause. Kathleen, I would like her to speak again somewhere else, maybe in the state, elsewhere. I would love to have her, all right? And Dr. LaGanke, he already knows what I feel about him, so, all right. Don't you? Got it, okay. So anyway, again, thank you, everybody. Thank you all for coming, because without you all, we couldn't have done this. So drive carefully, be safe, get home.